of PET imaging in myeloma. I think we often forget that functional imaging of myeloma actually started with a scan called a MIBI scan, which provided evidence of prognostic stratification, which was based on the pattern of involvement, and it was widely used in nuclear medicine. And many of the patterns that we look at now in MRI and PET were first defined on MIBI imaging, that patients with a normal scan had a much better prognosis than those who had diffuse involvement, and the worst prognosis was in those that had focal involvement on MIBI. Unfortunately, no one really likes SPECT these days. It's really an old technique. It's still widely available to most of us, though. The advantages of PET is it has a higher sensitivity for detecting radioactive substances, which means less radiation exposure, higher spatial and temporal resolutions, inherently 3D. It has quantitative capability, and we've heard twice how important numbers are to clinicians, and it does involve a lower radiation dose. And so we've seen this incredible revolution in scanner technology in the functional imaging domain, with first PET-CT and more recently with PET-MR. So many of the beautiful images that Christine showed us can also be acquired simultaneously with PET. So SPECT is very much like the old car sitting in the parking lot, and we've got the Ferrari now that's sitting out the front of these expensive hotels. We also forget, I think, that in CRAB, bone is very important, evaluation of bony disease. We've largely thrown away the bone scan because there's a mythology that bone scans are always negative in myeloma. In fact, they're usually positive, but what we miss is individual lesions. The technology for bone scanning has also very dramatically improved. With the onset of PET, you can use F18 fluoride, and if we just compare the cervical spine here, you can see the beautiful resolution that you get and the very high contrast that you can see between soft tissue and bony structures. But this is a fully 3D whole body acquisition that gives exquisite detail. Sorry, going back here. It gives superior target to background ratio. It's very fast. These images can be acquired in around 10 to 15 minutes on a modern PET-CT scanner. So it gives us beautiful evaluation of bony disease. And of course, we have the advantage of a low-dose CT so that we can identify lytic or sclerotic lesions with very high sensitivity, and also localization to look at their bony characteristics. And as you can see here, a lytic lesion in the pelvis, beautifully characterized as having focal osteoblastic activity at the edge of a lytic lesion. One of the things that hasn't as yet been pointed out is that while looking at bone windows is very important in the axial skeleton, that myeloma also affects the appendicular skeleton, and it's important to look at the marrow and routinely do this if you're doing PET-CT as well, to look at the marrow for focal areas of soft tissue density. This can be very helpful. How does FDG compare to MIBI? It certainly has much higher contrast and spatial resolution and generally wins, except in areas of high background activity. And there are certain areas such as around the bladder and around the brain where you may struggle to see lesions in close proximity to those very FDG-avid lesions. But nevertheless, you still get very good stratification, as you've seen with MIBI, that the number of focal lesions you need to get stratification is generally more. This is one study from clinical nuclear medicine where the most powerful stratification was between 4 or less than 4 lesions with the FDG, but you only needed 2 focal lesions on MIBI, and that really reflects perhaps those larger lesions that was pointed out as being very important on MRI. recent consensus guidelines, you won't be able to read this, but the Lancet Oncology paper suggests that it should be part of the initial investigations, but primarily because I think it's needed as a baseline for therapeutic response assessment. It is, however, a technique that has high sensitivity and has significant prognostic value, and that comes in two forms, based on the intensity of uptake, which is the SUV value. So if you have a higher than median SUV, you have a much worse prognosis than the low ones. And so, in fact, some of the data around negativity on PET being failing may in fact be a benefit, that low FDG may carry a different prognosis and tell us something about biology, which is very important. But tumour burden is also very important, so that if you look at the segmentation of all the areas of disease, that patients with a very low metabolic tumour burden, or total lesion glycolysis as it's sometimes called, have a much better prognosis than those with intermediate, and indeed a high tumour burden on PET is a very markedly adverse prognostic factor. And so if we look at univariate and multivariate analysis, in fact, although there are many clinical and imaging associations with prognosis in multivariate analysis, in this particular study, the only ones that reached statistical significance were the presence of 3 or more focal lesions on FDG, or the presence of extramedullary disease, both of which can be very well detected on PET. And so here's an example of a patient with diffuse infiltration of the marrow, as indicated by an increase in signal throughout the marrow, but more importantly, expansion of bone marrow into the appendicular skeleton. And that's a very important thing to look at in PET scans, is not only the axial skeleton, because we can see variable intensity of uptake in the marrow depending on the extent of fatty infiltration or fat replacement, but it's very unusual in adult patients to see significant extension into the appendicular skeleton. But as you can see here, soft tissue disease, which you can appreciate on the CT in the thoracic spine, but very difficult to assess in the lumbar spine, where it's extending into the psoas muscle. In terms of the ability of FDG to evaluate therapeutic response, this has already been alluded to as really a very strong technique. It's recommended for therapeutic response assessment in myeloma, particularly because the ability to have an early readout during treatment, so that there is a potential to change treatment. And as we've seen earlier, that it's quite a difference in prognosis between a negative scan and a positive scan. But clearly, there are still problems with this evaluation, because many of the patients with a negative scan are still failing. Every one of those drops down there is a patient who's progressed, and every one of the ones who drops on the overall survival is a patient who's died, despite having a negative imaging study. So we really clearly need to get better if we're going to try and evaluate the extent of disease. And I'd endorse what Christina said. We also have to incorporate clinical and particularly bone marrow findings and molecular markers of the disease, because imaging is always going to have a limbo bar under which cancer can scrape. But nevertheless, we are able to some extent, predict prognosis on the basis of the imaging results. The whole body PET scan is again very useful for looking at both axial and appendicular and soft tissue disease. But one of the real advantages of this technique is that partial volume effect, which we often see as our enemy in imaging, that we can't see very small lesions, becomes our friend when small lesions progress. They grow through the partial volume count recovery curve, and they get more intense with only minimal growth. And so in this case, for example, the increase in intensity of focal lesions in the femora clearly indicate that there's early progression of disease despite the the treatment of this patient, even though some of the lesions are clearly responding, and even though the paraprotein levels were going down, and indeed this patient went on to progress. The question was asked, is FDG the best, or indeed is it the only tracer that we might use for the evaluation of myeloma? And there are many, many targets on the myeloma cell that we could potentially look at. And people have looked at them. It's one of the good and bad things about nuclear medicine. We tend to muck around with tracer technologies. And so here's a comparison, for example, of fluorocholine. Fluorocholine is incorporated into cell membranes, so actively growing cells which are making new cell membranes will have increased fluorocholine uptake. It's incorporated into phosphatidylcholine. And so here you see two examples, one where in fact the fluorocholine scan is showing us multiple lesions that are non-visualised on FDG, whereas the patient on the right has a concordant pattern where all the sites are seen. But what does this mean? What are the prognostic significance? We don't know yet. These are really observational studies of counting lesions rather than characterising lesions. And we don't yet know how to incorporate these into management paradigms. Similarly, because paraproteins are made by myeloma, they need an increased source of amino acids to make the biomolecules, and therefore transport of amino acids into the cell might be a useful target. Indeed, carbon-11 methionine as an amino acid substrate for the LAT1 transporter has been shown to be quite sensitive for detecting myeloma, and so you can see a completely negative FDG PET scan, admittedly in an area close to the brain, but very intense carbon-11 methionine uptake, and this might be very good in the functional high paraprotein expressing or secreting myeloma. Another potential target is the chemokine receptor, which, as you can see here, a very concordant pattern between a commercially now available kit-based tracer called gallium-68 pentaxophore, which is highly concordant with the FDG, and this has some potential therapeutic advantages that this can be labelled with a beta-emitting radionuclide called lutetium, and then the patients can be targeted. So it's a so-called theranostic paradigm where a diagnostic agent identifies the expression of a target. It's then used therapeutically using a radioactive tracer, a bit like we've treated thyroid cancer for many years by doing imaging with iodine and then treatment with iodine-131. And as you can see here on the FDG after that treatment, complete metabolic response, even though there's still uptake in those tumours that are present. However, again, when we compare these traces, we realise that no test is perfect. That we see certain cases where the chemokine receptor agent shows us more disease than the FDG, and conversely other cases where the FDG shows us more than the chemokine receptor. So what does it mean biologically? I think we're still in the early phases of understanding how best to use the functional imaging to characterise the disease rather than simply counting the lesions in number and size. And this is, I think, the challenge for us as imaging and clinicians to work out how to integrate these techniques. And this is just a summary of the data. You see that over the course of patients compared with these two traces, and still FDG is probably the most sensitive of the tests. So it's good for detecting disease, but imperfect. What about other traces? As if we didn't already have enough, there are more. Here's one which is a so-called prostate-specific membrane antigen, something that's become very popular and will be, I think, widely available in many nuclear medicine departments in coming years because of its utility in evaluating prostate cancer. But there are now a number of case reports of showing really intense uptake of this tracer in multiple myeloma. what the target is, we don't know. It's maybe neovascularization and maybe very much more important for aggressiveness of the disease, but we're still, again, going to have to learn how to incorporate this into our treatment algorithms. And then lastly, we have the opportunity to also image therapeutic targets which are widely used by our hematology colleagues. Daratumumab as an anti-CD8 monoclonal antibody can be labelled with either zirconium or copper-64. There is examples, there are examples of both. And as you can see, intense uptake in this model of skeletal myeloma, very high uptake in the involved marrow. And so this might be something in terms of selecting patients and identifying therapeutic targets that might come into the diagnostic armamentarium. So I wish all of the imaging people in the audience good luck. Skeletal survey is still unfortunately widely used and encouraged by insurers and government, and as the first and best test. We all know it's not. And MRI and PET are still considered expensive and unproven modalities, at least to the funding bodies, even though they appear in our guidelines. And I'd leave you with a little bit of philosophy that human beings are almost unique in having the ability to learn from the experience of others, but are also remarkable for their apparent disinclination to do so. Douglas Adams. And with that, I thank my molecular imaging team. Thank you very much.